So, Alan, tell me, how about the use of imaging and with IFR co-registration? Many people tell me, they say, oh, well, I'd like to use an IVUS or an OCT run to plan my angioplasty. Does the use of IFR prevent you from doing so, or how do you marry that information together?
Well, it's a good question. I'm fortunate at St. Francis that we don't have a lot of restrictions in terms of finances.
Right.
So we are a very, very large imaging center. As you may know, we looked at our numbers last year. We had 84% of patients receiving PCI at St. Francis had imaging.
Wow.
So from our perspective, obviously the two are not
They're not mutually exclusive.
they're not exclusive. In fact, they work together very well.
Right.
So because you're looking at different things, with physiology, you want to know the first step, right? Do you need to treat or not? Should you treat or not, right? And then the second step is, if you do, how to do it, which is what the pullback does. But then the imaging gives you another layer, I think, which is important if you're really considering doing precision PCI, where you say, okay, let me find a landing zone that has maybe less than 30% plaque burden, right? Let me find a landing zone where the plaque is not lipid, because that will dissect for sure, or not calcium, right? Which is the best landing zone? What is the size? I think what is very common in stenting these days is that people undersize the stents based on the angiogram. We have a lot of data.
Yeah.
And all of the events are associated with minimal stent area. So if we can maximize that minimal stent area, we should reduce the event rate. And in fact, many IVUS trials have shown exactly that.
Yeah.
I think if you want to really, use or do the best you can, you probably will have to do imaging on top of physiology as well.
That's right. So using the physiology to guide where you do your intervention, and then the IVUS to help guide landing zones.
Right.
Because you've still got to stick to your
and sizing, right?
Yeah,
Sizing is key.
and
If you start doing imaging on a regular basis, what you find also is that you will have to do a lot more lesion preparation than you thought, based on the angiogram.
Yes.
So our rate of atherectomy actually is much, much higher because of that, because we identify calcium to a much greater degree. And we know that if you have calcified vessels, you can't expand the stent properly, and stent under expansion is a very strong predictor for adverse events.